Hello and welcome. We're so glad you could join us. Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. आज Anesthesia or Perioperative Medicine channel पर हमारे साथ जुड़ने के लिए धन्यवाद. 本日は麻酔手術器医学チャンネルにご参加いただきありがとうございます. Welcome, everyone. Today we are going to take a really deep dive into a topic that's fundamentally changing how we approach one of the most complex procedures we manage, enhanced recovery after surgery, or ERAS, in the world of liver transplantation. So here's our roadmap. First, we're going to lay the groundwork, what ERAS actually is and why it's such a big deal. Then, we'll get into the nitty-gritty of the foundational guidelines that everyone's talking about. From there, we'll zoom in on what this all means for us, with a practical anesthesiologist playbook. We'll then tackle the really nuanced world of advanced pain strategies, and finally, we'll pull back to see the bigger picture and where we're headed. All right, let's jump right in. Before we get lost in the details of protocols and guidelines, we need to answer two really basic but crucial questions. First, what exactly is ERAS? And maybe more importantly, why are we even talking about it in a field as high stakes and as complex as liver transplantation? So at its heart, ERAS isn't just one new technique or a fancy new drug. It's a complete philosophical shift in how we deliver care. Think of it as moving from a collection of individual, sometimes conflicting traditions to a structured team-based playbook. It's this multimodal, bundled approach that covers the entire journey, before, during, and after surgery. And every single piece of that bundle is designed with one goal in mind: to buffer the patient from the massive physiological and psychological stress of surgery.
And that's a really fair question, right? I mean, liver transplants are already unbelievably demanding. Our patients are often some of the sickest in the hospital. They're frail, they're malnourished, their coagulation is all over the place. So you have to ask, is adding a complex ERAS protocol just adding another layer of work? Or is there a real tangible benefit to be had?
Well, the why becomes incredibly clear when you look at the goals. Think of that huge surgical stress response as the first domino to fall. When it falls, it can trigger a cascade of really nasty postoperative complications, things we all dread like acute kidney injury, biliary problems, or even early allograft dysfunction. ERAS is designed to be a shield. It's meant to blunt that initial hit. By doing so, we're not just hoping for better numbers, we're aiming to accelerate true functional recovery, getting patients eating sooner, moving sooner, and ultimately getting them out of the ICU and home to their families faster. At the end of the day, it's about improving their entire experience. Okay, so we've got the what and the why down. Now, how does this broad concept actually translate into what we do every day? Let's get into the evidence and explore the two most influential sets of recommendations that are really shaping modern practice: the guidelines from the International Liver Transplantation Society, that's the ILTS, and the ones from the ERAS Society. First up, the ILTS guidelines. And just look at that number, 80. That's not a typo. We are talking about 80 final comprehensive recommendations that came out of their 2022 Consensus Conference. This isn't just a brief summary. It's an incredibly detailed, granular document that covers almost every single aspect of care for both deceased donor and living donor transplants. The sheer scale of this work is pretty amazing. So how in the world did they come up with 80 recommendations? Well, it wasn't just a few experts sitting in a room. They used a process called the Danish model, which is known for its rigor. It started with 32 different scientific panels, each conducting their own systematic literature reviews. Then their findings were presented at a huge virtual conference where nearly 300 specialists from 30 countries voted anonymously on every single recommendation. But here's the really cool part. The final step involved an independent jury of non-experts. And that's a deliberate step designed to reduce the influence of any single expert's bias, ensuring the final product is as objective as possible. So what did this incredibly rigorous process actually tell us to do? Let's break down this table for the deceased donor recipient. Preoperatively, you see a strong recommendation for risk stratification using tools like the Liver Frailty Index. Intraoperatively, things like maintaining normothermia and using a restrictive fluid strategy get strong recommendations. But now, I want you to look closely at that middle row for the intraoperative phase. The preference for volatile anesthetics over TIVA. Notice the evidence is graded as very low and the strength is weak. This is a really important nuance. It tells us that this is more of a suggestion based on common practice than a hard and fast rule backed by bulletproof data. And postoperatively, you see themes we expect, like avoiding opioids and early line removal, but again, with weaker evidence grades. Now let's completely switch gears and think about the living donor. This is a totally different ballgame, isn't it? We're taking a perfectly healthy person and putting them through a major operation.
So as you can imagine, the focus shifts dramatically to safety and comfort. Preoperatively, the strongest recommendation is for comprehensive counseling. And then look at the intra- and post-operative phases. Strong recommendations for multimodal analgesia and opioid reduction. The message is crystal clear. We have an ethical duty to do everything we can to provide excellent pain control and facilitate a rapid, smooth recovery for these incredible individuals.
Okay, next up, let's look at the ERAS Society's take. Their pathway is a bit more condensed, with 22 core items, but it hits a lot of the same notes as the ILTS. What's really interesting here are the things they strongly emphasize. Notice the huge focus on nutrition, not just screening beforehand, but getting patients eating again within 12 to 24 hours. That's a classic ERAS principle. But the one I really want to highlight is that last item, a strong recommendation for a systematic audit of compliance and clinical outcomes. This is the secret sauce of ERAS. It's not enough to just have a protocol on paper. You have to measure how well you're following it and whether it's actually making a difference. It's that feedback loop that helps you get better over time.
All right, we've seen the big picture from the major societies. Now, let's bring it home. In this section, we're going to put on our anesthesiologist hats and filter all this information through our specific lens. We're going to synthesize these guidelines into a practical, real-world playbook for us, the folks at the head of the bed.
I really love this quote because it just nails it, doesn't it? It perfectly captures our central role in all of this. We are not just passive bystanders in the ERAS process. We are key drivers. Our minute-to-minute management of intraoperative homeostasis, the anesthetic choices we make to enable early extubation, and our entire approach to pain management, these aren't just small components of ERAS. They are, in many ways, the absolute cornerstones that determine whether the whole thing succeeds or fails.
Okay, team, this is the money slide right here. Let's really park on this for a minute and put these guidelines head-to-head on the topics that we deal with every single day. The first thing that jumps out is the incredible consensus on the big stuff. Look at the bottom two rows. A MAP target greater than 60 to 65, universal agreement. A major push for early extubation, everyone's on the same page. This is great, it gives us clear, unified goals. But now, let's look closer at the nuances. Under anesthesia drugs, everyone leans towards volatiles, but the ERAS Society gets specific about preferring sevoflurane, while the Spanish Society adds a specific caution about intracranial hypertension. For monitoring, 2 of the 3 prefer MAC over EEG-based monitoring. This table is basically our high-level cheat sheet for understanding not just where we have strong consensus, but also where there's still some debate and room for clinical judgment.
So let's unpack that whole volatile versus TIVA debate a little more. As we saw, the guidelines kind of give a gentle nudge towards volatile agents. But we have to remember what the ILTS said. The evidence for this is very low. So what this really tells us is that this preference is likely based more on tradition and expert opinion than on strong, conclusive data from randomized trials. In the real world, our choice is often influenced by so many other factors, right? It could be our hospital's protocol, specific patient factors like that risk of intracranial hypertension. And increasingly, we have to think about the cost and the environmental impact of the agents we use.
Now let's talk about something that is absolutely our bread and butter: hemodynamics and fluid management. The message here is loud, clear, and consistent across all the guidelines. First, that MAP target of over 60 to 65 is our North Star. Second, a restrictive fluid strategy is key. The whole game here is to keep the central venous pressure, or CVP, low, especially during that critical dissection phase. Why? It's simple physiology. A lower CVP means less pressure in the hepatic veins. That translates directly to less bleeding from the raw liver surface. It's about being smart and goal-directed, not just letting the patient get dry. We use our advanced monitors, like a PAC or TEE, to give us the data we need to walk that fine line.
All right, let's shift gears to a topic that is absolutely central to ERAS, and one where we as anesthesiologists are really in the driver's seat: perioperative analgesia. This is a huge part of the puzzle because if you can't control a patient's pain, they're not going to mobilize, they're not going to deep breathe, and the whole ERAS cascade starts to fall apart. But in liver transplantation, it's not a one-size-fits-all approach. We're dealing with 2 very different patient populations.
This slide really captures the core challenge. Imagine you have 2 patients on your OR list. Patient A is the living donor, healthy, robust, and about to undergo a massive operation. Patient B is the recipient, critically ill with end-stage liver disease and completely unpredictable drug metabolism. For the donor, our goal is aggressive, excellent pain control to get them back on their feet as fast as possible. For the recipient, our goal is still effective pain control, but it's balanced by this overriding need for safety. We have to constantly worry about how their sick liver or their brand new liver will handle our drugs. You simply can't use the same playbook. So for our donor, we're building a fortress against pain. It's all about a multimodal strategy, attacking pain from multiple different pathways to get a synergistic effect. The foundation of this fortress is our scheduled non-opioids, like paracetamol. Then we bring in the heavy artillery, powerful regional anesthesia techniques that can provide incredible pain relief and dramatically cut down on our need for systemic opioids. This way, we can reserve opioids, maybe through a PCA pump, for just breakthrough pain, instead of making them the star of the show. So how do we choose which regional block to use? It really comes down to the surgeon's plan. If they're doing a classic big open laparotomy, a thoracic epidural is still one of our best tools. It provides fantastic continuous pain relief. But as more and more of these donor surgeries are being done laparoscopically, we have other great options. Ultrasound-guided transversus abdominis plane blocks, or TAP blocks, have become a go-to. They're less invasive than an epidural and do a wonderful job of numbing up the abdominal wall where the incisions are.
Now, for our recipient, the entire mindset shifts from attack to defend. Our analgesic strategy is defined by one word: caution. Opioid avoidance becomes the central goal. Why? Because with their altered metabolism, opioids can hang around for a long time, leading to delayed extubation and a much higher risk of postoperative delirium. Paracetamol is a safe and effective foundation. And while some regional techniques like TAP blocks are still on the table, I want you to look at the bold text here. This is the critical takeaway. A thoracic epidural is generally a no-go for the recipient. Their coagulopathy puts them at an unacceptably high risk for a catastrophic epidural hematoma. This is a crucial safety point.
Okay, for our final section, we've been really deep in the weeds of liver transplant ERAS. Now I want us to pull the camera back, zoom out, and look at this through a wider lens. It's so important to see how these liver transplant guidelines fit into the broader context of other major abdominal surgeries and to start thinking about the new challenges and questions that are on the horizon for all of us.
This is another really fascinating comparison table. It shows us just how much these different ERAS pathways have in common, but also where they diverge in critical ways. Look at all the things that are consistent. Pre-op counseling, goal-directed fluid therapy, keeping the patient warm, these are universal principles of good surgical care. But now let your eyes drift down to that very last row, the one about thoracic epidurals. This is where the paths split. It is explicitly not recommended for either liver resection or liver transplantation because of that bleeding risk. But for a pancreatoduodenectomy, or PD, it's still a recommended technique. It's a powerful reminder that ERAS is not a cookie-cutter approach. It has to be intelligently adapted to the specific pathophysiology of the surgery we're doing. And this really brings us to the final, and I think the most important and challenging question that we all have to ask ourselves in our own hospitals. The guidelines tell us to screen every patient for an ERAS pathway, but we all know the reality of that decompensated, high MELD score patient who is just barely hanging on. Is a full, rigid ERAS protocol truly the right thing for them? I think the emerging consensus is that it's not about exclusion, but about adaptation. The challenge for us moving forward is to get smarter, to move beyond a simple checklist and learn how to thoughtfully pick and choose the elements of ERAS that will benefit each individual patient. Our goal should be to extend the incredible benefits of enhanced recovery to even our sickest and most vulnerable patients. Thank you so much for your time.